Thank you very much for having me here. I thank the organizers and what wonderful topic names you have kept. I think that deserves a kudos. The wonderful topic name, interesting. By the time my slides are being uploaded, we just recently held a headache awareness program in PGI under the aegis of PGI Neurology Society and IAN. And one question which everybody in the hall almost asked us was that which headache should we be taking lightly? So I think that is one question which has always remained. And the answer was pretty simple. Should I start? I think it's here. The presentation is here. So yes, it's there. So this was the awareness program I was talking about. And one question which most of the people asked us that which headache should we be taking lightly? And the answer was pretty simple. You only need to take those people lightly who cause headache, which means you only take lightly the human versions of headache. No other headache should be treated lightly. So what are we discussing today? Why are we discussing today? What we are discussing today is those patients, recognition of those patients who should not be sent home by any means without an investigation or without MRI or without a proper clinical examination. So recognition of those patients are important. Primary headaches, we all know, is migraines, TTH, chronic daily headaches, which may actually be just led through without very huge investigations. But these secondary headaches, the headaches which are due to a structural cause, a hemodynamic cause, a vascular cause, cannot be sent home without investigation. And that is what I'm going to discuss today. So diagnosing secondary headache, we have lots of mnemonics which have been coming since time immemorial, I would say. First Snoop came, and then Snoop 2, and then Snoop 3. Now we have Snoop 10. So very quickly running through this Snoop mnemonic is whenever a patient has a systemic sign, whenever the patient has a neurological sign which can be elicitable like a focal deficit, whenever the headache is sudden or hyperacute, whenever the onset is in pediatric or geriatric age group, any pattern change, any progressive headache, any headache precipitated by a postural change, a Valsalva maneuver, presence of papilledema, headaches in pregnancy, especially the headaches which change their character, and whenever the phenotype of headache is rare, like associated with autonomic features, associated or increased by exercise, induced by cough or in sex-induced headaches, can never be taken lightly. And then these mnemonics kept building up. And we have now addition of these three more things. So post-traumatic headache which is associated with pathology like that of immune system, like in HIV, or whenever there's a painkiller abuse, we cannot take them lightly. So because I was told to keep this talk case-based, I'll directly begin with a case example. And they're simple cases, cases which we see daily. But how do we not take them lightly is what I'll discuss. So this is a 31 years old female who has history of migrainous headaches in past and who has decreased sleep, a very, very common occurrence in ROPDs. Now she's come with history of increase of that same corrector of headache for past 5 months, and now the headache has also started to occur in the frontal and the periorbital region. The headaches would increase during the menstrual cycle, and because of this reason, the patient was very well thought that the patient might still be having migraine, and all these medications which the patient was already taking, the NSAIDs, the beta blockers, tricyclic antidepressants were raised. And they kept on increasing, and the fundus was told to the patient was normal. But when the fundus was seen again, this is the picture of fundus. Just take your attention towards the right side optic disc of this patient. So though the margins are clear, what do we note? We note that the right side eye of the patient is pale. Now, this seen isolatedly, you might miss this finding. But what we need to do is to compare it with the other eye. And now you can really see that the pallor is pretty obvious in this eye. I hope this is clear even in the images which have been seen. And there was some enlargement of the cup. So of course, this was disc pallor. And we went ahead and did this MRI, and yes, what we have is this basifrontal meningioma. So it's important to know, and it's important to master the art of fundus examination. Many a times we might be getting confused. The best thing is to compare the patient's fundus with the other. Both the eye fundi should be compared. If we'll not do so, and if this patient was allowed to progress and allowed to have and not being treated well in time, this was what was going to happen, the Foster-Kennedy syndrome. So optic atrophy due to compression of the optic nerve, and because of increasing mass effect, increasing intracranial pressure, papilledema of the other eye, and this is known as the Foster-Kennedy syndrome. Let me take you to second example now. So this time it was a 17 years old NEET aspirant. Now, this boy was complaining of headache on and off with sleep deprivation. All NEET aspirants would be having it with eye strain, heavy head, and decreased attention span. So initially, the patient was, it was just attributed to whatever the patient was studying because of sleep deprivation. But subsequently, the patient was taken to an ophthalmologist because of eye strain, and the patient's visual acuity was seen to be 6 by 6. Fundus was showing disc edema, and the patient was sent to the neurologist to rule out idiopathic intracranial hypertension. But the MRI was normal. But what should have been done well in time? Anybody? So let me tell you. So this was done well in time, and the patient's BP was seen, and it was 220 by 160 millimeters of mercury. So where did we miss? What did we miss? Let's see the disc edema of this patient. Now this is, you can see the disc edema of the right eye very nicely, and you can see the disc edema of the other eye also very nicely with some peripapillary hemorrhages. But what are these hemorrhages like? Look at these vessels. So these hemorrhages are going along the vessels. These are typical flame-shaped hemorrhages. Along with that, what you see in the rest of the fundi are these cotton wool exudates, both hard exudates as well as soft exudates. Soft are the ones with irregular margins, and hard are the ones with established margins. So you can see lots and lots of exudates. And what else do you see? You see this macular star, partial macular star appearance, which is getting formed due to the release of proteinaceous substance of the inflamed vessel. So having looked at this fundi or these fundi, you need to be sure that this is a hypertensive retinopathy and this is not a classical papilledema. Papilledema, you will not have these flame-shaped hemorrhages, and if there are hemorrhages, they will not spread across the retina. And you might not have these cotton wool exudates. And what is the dictum? The dictum is that no patient of headache should be sent home without a disc examination and without the examination of pulse. Always hold the patient's hand while you see the patient and hear the throb without a BP, which is supposed to be recorded. Subsequently, this patient was seen to be having moderate anemia, shrunken kidneys, raised creatinine, and prominent left ventricular hypertrophy, all suggestive of chronic hypertension, which was never seen in a prolonged period. So this was about this patient, and now let's take this example of an elderly patient. Now, 77-year-old male patient comes to us with a new onset headache. So new onset headache and elderly patient. So both these things should have been enough for the patient to get investigated, but he did not get investigated, only to lose his vision after 2 days of having this headache. And this time, the vision loss was sudden and diffuse. The patient was having negative perception of light in both eyes. Retrospectively, he did have jaw pain. Message, you all know, jaw pain, headache, any headache in elderly actually should be evaluated at least with an ESR and a CRP, both of which were raised in this patient. Temporal artery Doppler of this patient was normal, but see this fundus. So both sides you see pale disc and you see these cotton wool exudates, and this is all despite the fact that the MRI is normal. So despite the fact that the patient was having a normal temporal artery Doppler, a temporal biopsy was done, temporal artery biopsy was done, and this is what you see. You see intimal proliferation, you see break in elastic lamina, and you see RBCs in tunica media. So message, lesson, any new onset headache should be evaluated. Any headache in elderly cannot be taken lightly. At least see for the signs like jaw pain, polymyalgia, see the BP, see at least ESR and CRP, and preferably do an ultrasound of temporal arteries. And even if it's normal, go ahead with the biopsy whenever there's a clinical suspicion. Now, another elderly patient, this time 71 years old lady, referred to us from movement disorder clinic because the patient was having idiopathic Parkinson's and the patient was very well controlled on levodopa. But now this patient developed acute onset headache along with vomiting and mild pain in the right eye. There was some scalp tenderness, so very well, the patient was seen and as ESR CRP was sent, which was normal. The patient was having a bad vision, but then she was also having dense cataract. So we did not know, they did not know how to see the fundus, and they sent the patient to our OPD. And what did we see? We saw that the intraocular pressure of this patient was heavily raised, and there was also shallow chamber, anterior chamber of the left eye. So acute angle closure glaucoma needs to be ruled out in patients, specifically in elderly patients, specifically when they have local signs, specifically when the pain is around the eye. Whenever there is mild redness or even any ocular complaint, it should be ruled out. Remember that even dopaminergic drugs like levodopa can have ability to increase the aqueous humor flow and increase the intraocular pressure. And these are very commonly used drugs, antimuscarinic drugs, tricyclic antidepressants, and they can all precipitate acute angle closure glaucoma. So this was about elderly patients. Now this young neurosurgeon, 40 years old male, had new onset exclusive headache during operating around 7 days before he presented to us. And during that while, he also had a transient loss of vision. And rightly so, he got a CT done and the CT was normal. And then he thought that I'll get my MRI done. Maybe after in some time, I'll just get it done because I've been having headaches now recently. But this headache recovered over the day. Patient was busy. And then he has another bout of thunderclap headache with altered sensorium. And this time, he also gets a seizure. And when he woke up, he was having vision loss. And as what you can think of, so before he woke up, we got the CT done, of course, when the patient presented to us in emergency. And what is there? There is a subarachnoid hemorrhage in the left sylvian fissure. Along with that, you see a hypodensity here, maybe due to vasospasm, and there was an ICA bifurcation. So what is important over here? Even in young patients, the suspicion of sentinel headaches has to be high. Even when the patient is having a normal CT, even when the patient is having a normal CT angiogram, in case the patient has presented with thunderclap headache, even with a transient focal deficit, the patient should be evaluated in further to the extent that even lumbar puncture should be done. It's very difficult to know which headache is a sentinel headache, but in case it's thunderclap headache, it should be evaluated. So why was the patient having loss of vision? Now see the fundus of this patient. What do you see? You see these subhyaloid hemorrhages, which may be getting confused with vitreous hemorrhages. So this is Terson syndrome, which occurs because of subarachnoid, because of intracranial pressure, which increases. And because of that, the subarachnoid blood may enter into the lamina cribrosa, entering into the paravascular spaces and causing Terson syndrome. This blood usually resolves over time in case there's no, again, increase in intracranial pressure, and the patient's vision usually improves. So lessons learned: worst headache of life, thunderclap, cannot be taken lightly. Sentinel headaches have a low threshold. Do an angiogram and also go on to the extent of doing a CSF examination whenever there is a thunderclap headache. So another example of Terson syndrome, this time this was an 18 years old lady who had history of dehydration in the form that she had lots and lots of vomitings, and then she started to have headache. And you all know what we'll be thinking in case that's the issue. So dehydration followed by excessive headache, you know that you need to rule out cerebral venous sinus thrombosis, CVT. And this is what this patient was having. This patient was also having this Terson syndrome, and we subsequently reported it in Neurology, which was published on the cover page. Lesson learned. So recent history is very important to elicit in case there's dehydration followed by headache. Do think it can still be CVT. Have a low threshold of imaging, and of course, fundus examination is needed in every patient. So while this was about the fundus examination, another examination which is also very important in the patients with headache is the pupillary examination. So look at this example. 65 years old lady had sudden onset severe headache with altered sensorium, but this was all 4 months back. The patient was left with the right eye ptosis and mildly blurred vision when she became conscious, and the patient CT and the angiogram was done outside, which was told to her to be normal, and the patient after 4 months presented to us like they do in tertiary care hospitals. So they'll see a lot of doctors and then they'll come to us. So you can see over here the dilated pupil of the right eye as compared to the other eye. And this is what cannot be left and cannot be taken lightly. So we again repeated an angiogram, which was normal. A CT, which was reported to be normal, probably had some mild subarachnoid hemorrhage. And because angiogram was normal and we had a very high suspicion, we went ahead with the digital subtraction angiogram, and it was showing a posterior communicating artery aneurysm. So important to remember that these are all sentinel headaches. The patients may have it, and whenever there is a pupillary abnormality, it cannot be taken lightly. And you know why? Because the aneurysm will be pushing the oculomotor nerve from outside, and the pupillary fibers, where do they lie? They lie in the outside, in the periphery of the oculomotor nerve. So this was about the dilated pupil. There's another spectrum. Now this time, a 38 years old male, again presented with right-sided temporoorbital headache and neck pain of 4 days duration. And this headache was stabbing. It was not getting relieved even after taking NSAIDs and indomethacin. And now you notice what's over here. So have a look at this picture. You may note that though apparently it looks normal, but the patient is having slight swelling of this lid. The patient is having slight ptosis. And if you see nicely, there is also right pupillary constriction. So what are all these things highlighting? They are highlighting autonomic changes. So along with headache and these autonomic changes, the patient should be evaluated for an angiogram along with MRI. MRI was normal, but the internal carotid artery was showing the string sign, this double lumen sign, both suggestive of dissection. So that's another very important cause. And whenever you see a pupillary abnormality, you can, of course, not take it lightly. So you know why this occurred? It occurred because of the sympathetic fibers which are around the internal carotid artery, the affection of which caused these autonomic symptoms and caused headaches. So remember, periorbital, facial, continuous, non-throbbing pain with autonomic symptoms cannot be taken lightly. So this is a common example where we all see in our OPDs. So obese 34 years old female presented with headache on awakening from sleep of 15 days duration with transient visual obscuration and blurry vision. Though she complained of blurry vision, the vision was normal, 6/6 both sides, and the patient had papilledema. And the patient also had almost normal visual field with mild scotomas and mild enlarged blind spot. All the features of increased intracranial pressure were present in this patient. You can see this globe indentation over here. You can see these tortuous optic nerves, and the venogram was normal. This is a classical example of idiopathic intracranial hypertension. We see it very often, and also now that I'm following a lecture on obstructive sleep apnea, even IIH has a very close association with OSA. So this is a common scenario, but what needs to be known is that early morning headaches, projectile vomiting, transient visual obscuration, papilledema, any postural change of headache, any headache which is increasing on Valsalva, pulsatile tinnitus, or is associated with spontaneous CSF rhinorrhea. All these can be associated with increased intracranial pressure. And that day we saw IIH. Tomorrow we may see hydrocephalus, a mass lesion in the brain, or any other pathology causing increased intracranial pressure. So why do these patients have normal vision? They have normal vision because where does the papilledema occur? It occurs in the periphery of the optic disc. And it's the peripheral retinal fibers which enter through the periphery of the optic disc. So once it gets elevated, it's the peripheral fibers which get involved first, leaving these patients with normal visual acuity, but with some visual blurring. And subsequently, in case they are not treated, the patient will have a whole field loss. The other signs of increased ICP are these macular stars or these patterns folds, which are lines which are left after a chronic disc edema has resolved or is resolving. So remember, these can also be suggestive of increased intracranial pressure. So another cause of increased intracranial pressure, specifically in the partum, antepartum, postpartum area, is a cerebral venous sinus thrombosis, and that's what this patient was having. A 22 years old lady, 32 weeks gestation, had new onset headache, and was having disc edema, and was having cerebral venous sinus thrombosis. So this is another thing which cannot be taken lightly. Anyways, any headache in the pregnancy cannot be taken lightly. Why? Now look at this example. 25 years old primey, presented with headaches which had increased in 15 days and was associated with some diminution of vision of both eyes. The BP was seen to be 150/100, and because the patient had presented with seizure, the gynecologist thought that it was all eclampsia, and it was treated. Emergency LSCS was done, and the baby was delivered. But the patient kept having headache. Any headache in pregnancy should be evaluated, and this is what this patient was having. The patient was having hyperintensities suggestive of vasogenic edema, which were not restricting on diffusion-weighted images. So what needs to be known is that these patients will have normal angiogram, normal venogram, and PRESS, which is the posterior reversible encephalopathic syndrome, is an important entity and should be ruled out in pregnancy whenever these patients present with headache. So now this another patient, this time 22 years old lady, again primey, 28 weeks pregnancy, presented with new onset headache of 15 days duration and some blurred vision. But vision was normal, and so was the fundus. So what was missing over here? What was missing over here was this visual field. So while we see for the visual acuity and we see for the fundus examination, also remember to see visual fields. even if it counts to your confrontation testing, and if possible, of course, a visual field analysis. Now, what is this? This is bitemporal hemianopia, and what did this patient have? You all know the patient had apoplexy during pregnancy in the pituitary macroadenoma, which was there, and within 2 days, the patient regained the vision and the headache stopped. So, visual field examination is another important point which should be always taken into the consideration. So while I'm discussing all these causes, it's important to know that any affection of dura will be associated with headache. So be it this patient who presented to us with double vision, headache, and drooping of eyelid with a visual acuity of around 6/9. But because the patient was having ptosis and the patient was having double vision, you can see what was happening to the dura over here in the cavernous sinus, and this patient was having IgG4 related disorder. So it needs to be known that hypertrophic pachymeningitis is an important cause of headache, and whenever there's a suspicion of any mild focal deficit, the patient should be evaluated with MRI, and they can be having the hypertrophic pachymeningitis is almost like a symptom. It needs to be further seen for the cause. And like you can just see over here, I'll be concluding very quickly. So this was Rosai Dorfman over here. In case sinuses are involved, you need to rule out a fungal infection. And in case there is an orbital inflammation, you also need to rule out disorders like sarcoidosis. So I'll not take much time, but now this is the last spotter, 48 years old female presented with severe headache. The headache was that bad that the resident came to me and was telling me that I'm very sure that this patient will end up having a psychogenic type of headache. Patient was shouting at the top of her voice, and the patient was sent to emergency, and the CT came out to be normal, and so did the angiogram. But because patient was having severe headache, next day MRI and MR venogram was repeated, which was also normal. She was planned for CSF that day, but on the very third day, this is what started to develop. So these are what? These are lesions, the hepatic lesions. So these are the ones which can really confuse you. You must follow up the patient, any patient who presents to you with thunderclap headache. And what is the message learned from this case is that herpetic lesions or herpes per se can be a master mimicker. You may study all and may still miss one, but still you should keep it into possibility and follow the patient up. So these are the key points. Remember to see the fundus. Remember pupillary examination, to check blood pressure, at least do a ESR and CRP in all patients who are elderly and presenting with headache. Remember that none of the systemic and neurological signs can be taken lightly, and in all pregnant patients, a watchful observation is required even if their imaging is negative. So with this, I end this presentation and invite everybody to the next National Conference of Neuro-Ophthalmology, which will be there on February 2025. Thank you.
Thank you, Dr. Aastha.